Hi, everyone. Welcome to today's Echo session on optimizing pain management, exploring sleep architecture, cannabinoids, and consequences of untreated pain. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original people in what we now know as Canada. And we are grateful to have the opportunity to be present in this territory. Briefly, the Palliative Care Echo Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness. We encourage you to check out our website that you see on the screen before you, and I'm going to send a little link into the chat as well to be up to date with what sessions are taking place. The Palliative Care Echo Project is supported by a financial contribution from Health Canada. Therefore, the views that will be expressed here today are not necessarily the views of Health Canada. Many of you might know Pallium for our LEAP programs and our LEAP content. Predominantly, LEAP Core is an interprofessional course that focuses on the essential competencies to provide a palliative care approach. It can be delivered online or in person, and it is double accredited by the CFPC and the Royal College. Briefly, I'm going to introduce myself and our presenters. My name is Diana Vince. I'm the Palliative Care Echo Project Manager at Pallium Canada. I have the pleasure of allowing to introduce Amy Archer and Disa Clifford. Amy, if you'd like to briefly introduce yourself.
Thanks, Diana. Such a privilege to be here. Thanks for having me. Thanks for having us. I'm Amy Archer. I'm a registered nurse by background and an osteopathic manual practitioner. I'm also a clinical co-lead for Ontario Health in the Central East, and I love teaching Pallium. I'm a Pallium lead facilitator. So this is my first Echo. I'm happy to teach in this platform too. Thank you, Diana.
Thank you. It's thrilled to have you. Amy, Disa?
Hi, I'm Disa Clifford. I'm also a nurse by background, and I'm a palliative pain and symptom management consultant working in Toronto.
It's wonderful to have you with us, Disa. So a few welcome and reminders for comments and introductions. I do see a few of you. Please feel free to introduce yourselves in the chat. We'd love to hear what is your profession and where are you joining us from. For any questions, I'd like to invite you to please use the Q&A function. The questions will be addressed towards the end of the session, and the session is being recorded. The recording and the slide decks will be emailed to all registrants within the next week or so. Please remember not to disclose any personal health information during the session. For the conflicts of interest, Pallium Canada is a non-for-profit organization, partially funded through a contribution by Health Canada. We also generate funds to support operations and research and development from course registration fees and the sale of our pocketbook. I myself, along with the presenters, have the disclosures that you see before you on the slides. And without further wait, I will now pass it along to Disa.
Thank you so much, Diana. So today we're going to talk about optimizing pain management, exploring sleep architecture, cannabinoids, and the consequences of untreated pain. So pain management, as we know, is a core tenet in palliative care, and optimizing pain management is crucial to supporting the quality of life and holistic well-being of the individuals that we care for. Unrelieved pain is the universal complicator because it worsens all coexisting medical and psychiatric conditions. And as said by Dr. Daniel Carr, the director of the New England Medical Center, chronic pain is like water damage to a house. If it goes on long enough, the house collapses. Untreated chronic pain causes the body's fight and flight response to acute pain to become pathological, which can then lead to chronic cardiovascular stress, hyperglycemia, which can predispose the person to or worsen existing diabetes, and impaired digestive function. At this point, persistent or chronic pain is no longer a passive symptom of an underlying disease process or painful trauma, but becomes a disease in its own right, due to the continuous flow of pain signals along pain pathways, resulting in aberrant functioning of a pathologically altered nervous system and altering the structural pathology in the periphery, spinal, and cortical levels, and resulting in central sensitization, which Amy will now speak more about.
Yeah, so in chronic pain, oh, I have to advance that slide, sorry. I don't know if I did that or not. In persistent pain and in chronic pain, the nerves become more sensitive to stimuli. So we have this picture here of this brain being on fire. So if we think of neurotransmitters as constantly firing, creating stimuli, it's a consequence of the maladaptive changes in the nervous system saying, I'm in pain, I have this untreated pain. So central sensitization is a pathophysiological process where that central nervous system undergoes structural, functional, and chemical changes to become more sensitive to the stimuli. It's persistent and highly active state because our body is trying to create homeostasis and balance and manage pain. So it's acting and saying there's a painful stimuli, but that painful stimuli may not actually be there. So the nervous system is truly on fire and flooded with those signals that continuing to move to help modulate the pain. But even when there's no apparent tissue damage, so it's the constant signaling. So the central sensitization has potential to occur when acute becomes chronic or continues to be persistent. So many of the individuals who we care for who have chronic persistent pain have the potential to be in a central sensitization. So central sensitization also can be associated with mood changes, fatigue, cognitive changes. We'll talk about sleep today. So sleep changes, memory loss, anxiety, as well as depression. So there's this trifecta of central sensitization where you get hyperanalgesia. So painful stimulus becomes even more painful, even in the presence of analgesics. Then they move into a state called allodynia. So that's when there's a non-painful stimulus that actually becomes painful. So it's those individuals you care for, you put their clothes on or the sheets on over the bed and they say, ow, 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 this is hurting me. Or the fan is blowing in their face. And even that sensation becomes painful. Or you approach them for care and even your touch is too painful for them. So there's a global sensory, that the third one of that central sensitization is that global sensory hyperresponsiveness. So they get extremely affected by external or internal stimulation. So noise, smells, food, they don't want to eat. Any external sensory stimulation can be very overwhelming for these individuals. Next slide. So the consequences of untreated pain are truly holistic. So we have that physical, we also have emotional and psychological when we think about the whole person. But I want to highlight that physical domain, like the endocrine system, is that you're constantly moving into this heightened state can affect metabolism, then your cardiovascular system, tachycardia, hypertension, there's pressure building in the system. The immune system becomes suppressed, there's slow healing, they're at greater risk of infection. The musculoskeletal system, so you have pain that's actually impacting the physical body, the musculoskeletal system, so you can have impacts to different areas. So if you can see here that whole system is impacted. And then next slide. I don't think I'm advancing the slide. So Diana, I'll get you to go to next slide, please. Thank you. And then you have the psychological impact to untreated pain. So individuals will have cognitive impairment. They can have memory loss, attention deficit. When you're in the presence of unmanaged pain, it's all you can think about. It's all you can see. And then that abnormal brain chemistry, when you have that central sensitization, those neurotransmitters are constantly firing. And so it creates definitely a chemistry imbalance. And that excessive electrical, I love even those words, the electrical activity, to make us think about the untreated pain and that consequence of like you constantly have things firing through your body. So of course, the research tells us it leads to increased depression, like I said, suicidal ideation when people think there's no there's no way to get relief except to end the suffering. And there's also prevalence of other mental health issues for these individuals, so other disorders who are experiencing untreated pain. Next slide. So Disa is going to walk us through the sleep architecture and the importance of good sleep for pain management.
Thanks, Amy. So we just saw how sleep impairment is a consequence of untreated pain, but sleep also plays a significant role in the pain experience. And the bidirectional relationship between pain and sleep is widely acknowledged, but studies are now suggesting that there's actually a stronger effect of sleep impairment on pain than pain on sleep. And more than 2/3 of chronic pain sufferers report sleep issues, and approximately half of people with insomnia also report chronic pain. So we can take from this information that supporting good quality sleep is essential in order to optimize pain management. So sleep loss alone impacts cognition, decision-making, psychomotor function, mood, and immune function. And it's also a risk factor for cardiovascular disease, dementia, obesity, diabetes, depression, cancer, pain, and mortality. But of course, experiencing both sleep impairment and pain are also going to have additional consequences on many aspects of that person's life. So they may be more likely to experience depression, anxiety, suicidal ideation, and catastrophizing. There may be additional impacts on immune function and cardiovascular risk factors. Their social relationships and interactions could also be affected. Sleep impairment and chronic pain can impact the person's functional abilities and lead to less physical activity and/or greater disability. And this will also have socioeconomic implications for the person, affecting their ability to work, potential need to be on disability, as well as healthcare related costs. And having chronic pain and sleep problems also increases the likelihood that that individual's pain is going to be more severe and last longer. So now we can look at the different stages of sleep and what normal sleep architecture looks like. So there's 2 stages of sleep, non-rapid eye movement and rapid eye movement. And then the non-rapid eye movement stages are further broken down into 3 stages. So N1 is the transition from awake to asleep, and this is the lightest phase of sleep. It's categorized by brain waves that are starting to slow and rolling eye movements, and regular breathing. And oftentimes people are not actually aware that they're asleep when they're in this stage. N1 sleep is easily interrupted by noise. And so someone might be in N1 sleep if they would wake up when their name is called from a different room in the house, depending on how large your house is. N2 is the second stage of light sleep. And this comprises the largest percentage of total sleep time for normal middle-aged adults. So about 45 to 55% of your total sleep time. In this stage, there are minimal to no slow eye movements, and the heart rate and body temperature start to drop. This is the stage that's thought to be essential in transferring information from short-term to long-term memory. And the person is going to be harder to awaken from N2 sleep than from N1. So now they might wake when their name is called from just outside their bedroom. So N3 sleep is also known as slow wave sleep or deep sleep. And this is the most restorative phase of sleep. In this stage, the person will be difficult to awaken. So you might need to be right next to them or touch them to wake them up. And when somebody wakes from N3 sleep, they may have mental fogginess for about 30 to 60 minutes after waking. This phase is essential for the body to repair and regrow tissue, build bones and muscles, and strengthen the immune system and support memory. Insomnia and other sleep disorders can cause a person to spend less time in this stage, as well as people spend less time in N3 sleep as they age, and they spend more time in N2. And the final sleep stage is REM sleep. And so this phase is associated with vivid dreaming and is not actually considered restful because brain waves are similar to those of being awake. Skeletal muscles are atonic and without movement, except for eyes and diaphragm muscles, which remain active. And heart rate and respiratory rate are also more erratic. So here we can see how we cycle through our sleep throughout the night. And while sleep processes may not be the same for every single person, there are typical patterns of non-rapid eye movement and rapid eye movement sleep. So a single cycle lasts approximately 90 to 120 minutes, with between 3 and 5 cycles occurring in a typical 8-hour night of sleep. So we can see N1 in yellow on the slide, and that lasts for about 1 to 7 minutes and is approximately 5% of the total sleep time. Then N2 we can see in teal, and the first N2 stage is about 10 to 25 minutes, and then we can see how it lengthens throughout the night. And again, this is the stage that comprises the majority of a night's sleep at about 45 to 55% of total sleep time. Each N3 stage of sleep in light blue is between 20 and 40 minutes and about 25% of total sleep time. And we can see that N3 occurs more longer in the beginning of the night and then decreases throughout the night. And REM sleep begins about 90 minutes after sleep has started and increases throughout the night. So we can see REM sleep in the dark blue, with the first cycle maybe being around 10 minutes and increasing to around an hour by the end of the night. And so all of these stages, and especially the restorative N3 and slow wave sleep phase, are needed to have a restful sleep. So then how might we know if a person is getting restorative sleep? So first and foremost, are they waking feeling rested and refreshed? Do they have daytime drowsiness? Do they need to nap frequently throughout the day? That's going to indicate to us that they're maybe not getting restful and restorative sleep. Do they remember their dreams? So while dreaming can occur in any stage of sleep, it's quite uncommon in N3 sleep, and vivid dreams are more associated with REM sleep. So remembering vivid dreams might suggest that the person is not getting restorative sleep. And is the person waking up frequently throughout the night? This is going to prevent them from cycling through the different sleep stages and getting their restorative and restful sleep. As well, nociceptive stimuli are more easily interrupt lighter phases of sleep, so N1 and N2, than they do N3 and REM. And nociceptive stimuli produce more arousals than non-nociceptive stimuli, so non-painful. So therefore, pain may be preventing the person from reaching those deeper stages of sleep. So the sleep-wake cycle is also regulated by circadian rhythm, our 24-hour internal clock. And ideally in the evening, when the sun goes down, melatonin is produced and induces sleepiness and decreases core body temperature to promote nighttime sleep. Then melatonin production stops in the morning with light exposure, the core body temperature rises, and the person wakes up. And because light and dark regulate the circadian rhythm, we can see a lot of sleep disturbances in well-lit healthcare facilities. So for example, we may have situations where a person is agitated or restless in a facility like a hospital or long-term care home, and maybe they're brought to the nurse's station at night to be monitored, but this is going to significantly disrupt their sleep architecture and their circadian rhythm. So just things to be cognizant of. So this slide shows us that there are a lot of factors that increase sleep deprivation, the risk of sleep deprivation or disruption for the individuals we care for, families, as well as ourselves as healthcare providers. So one of which is shift work that we all know very well. And simply being a caregiver for a person with serious illness is a risk factor for sleep deprivation. And so that's so important for us to keep in mind when in our care, family and person-centered care and palliative care. Environmental factors are risk factors for sleep deprivation, such as excessive noise and light, like we just spoke about. Stress and depression can decrease N3 stage sleep, and as well as medical conditions such as pain or cardiovascular disease, restrictive lung disease, neurodegenerative diseases like dementia and Alzheimer's decrease N3 sleep, and the use of certain medications. So many of these medications that we use in palliative care for symptom management have the potential to affect sleep. So opioids increase wakefulness and decrease total sleep time when used chronically, and they decrease N3 sleep and REM sleep at higher doses. However, of course, they may have a positive impact on sleep if sleep disturbance is caused by pain. NSAIDs impair sleep by inhibiting prostaglandin synthesis, which is thought to promote sleep, but no studies have shown alterations in sleep architecture. All antidepressants, except for SARIs, suppress REM sleep. Tertiary TCAs, like amitriptyline, decrease sleep onset latency and wakefulness after sleep onset. MOAIs increase wakefulness and decrease total sleep time. SSRIs increase N1 sleep and wakefulness and decrease total sleep time. And for SARIs like trazodone, studies are inconsistent, but 50% show improved sleep quality. So most studies do show that trazodone increases N3 sleep, while nifadazone decreases N3. For glucocorticoids, the belief of sleep disruption is widely accepted, but is primarily based on patient reports, as they haven't been well studied. But the limited evidence does suggest that they are associated with REM sleep suppression and increasing waking after onset. And they may also cause restlessness and a decrease in natural melatonin levels. Atypical antipsychotics suppress REM sleep and increase N3. Beta blockers suppress REM sleep and may also reduce natural levels of melatonin. And lipophilic beta blockers are associated with nightmares, insomnia, and daytime sleepiness. And CNS stimulants increase sleep onset latency, wakefulness, and N1 sleep, and decrease N3 and REM sleep. And so this list is not by any means comprehensive of all the medications that have the potential to affect sleep, because we can see some medications that may directly impact sleep architecture, but other medications may have side effects or mechanisms that also result in sleep disruption. So what are some of the ways in which we can promote good quality sleep? Good sleep hygiene is essential. And so this involves having a regular schedule or a bedtime routine, having a safe and calming sleep environment in order to promote rest and reduce stress. So if somebody is in a hospital or long-term care, trying to make their room and their space around them very calm, not cluttered, to really give them that safe space. Avoiding stimulants too close to bedtime. So this can include caffeine and alcohol, but it also includes screens, which I think we probably all have issues with seeing screens too often close to bedtime, but the blue light can impact our natural melatonin production. So also decreasing daytime napping or having naps too close to bedtime. So if a patient isn't sleeping throughout the night, but they're napping consistently throughout the day, then they may not have the sleep drive that they need to fall asleep or stay asleep at night. And exposure to sunlight in the morning by opening the blinds or going outside can also help regulate our circadian rhythm. And cognitive behavioral therapy for insomnia, for pain, or using a combined approach can also help with promoting good sleep quality. And so while we can see the evidence of the relationship between sleep and pain, the actual mechanisms underlying this relationship haven't been scientifically proven, but there's several potential mechanisms that have been hypothesized, some of which we can see on the slide here. So number one that we see on the slide is endogenous pain modulation. And so pain facilitation and inhibition mechanisms have been found to be altered in people with insomnia, with women more susceptible to sleep deprivation effects in EPM than men. And studies have also shown an association between sleep disruption and experiences of mild increase in spontaneous pain, decrease in time of heat pain thresholds, decreased pain habituation, and central sensitization and hyperalgesia. For inflammation, pro-inflammatory cytokines play a key role in the development of inflammatory and neuropathic pain, but also in sleep regulation via the central nervous system. Increased cytokine levels can be seen in response to short or disturbed sleep and may indicate a state of low-grade inflammation, which then, if in this state chronically, may increase the risk of various health conditions and potentially worsen chronic pain and further disrupt sleep. So get us into a nice cyclical cycle of worse sleep and pain. Affect and mood have mechanisms in the sleep pain relationship, with a higher positive affect appearing to be a protective factor, as lower positive affect and sleep disturbances are also associated with increased inflammation. And studies have shown that greater catastrophizing is associated with greater sleep disturbance and a higher pain intensity. So this is where our cognitive behavioral therapy approaches can come in with treatments aimed at improving affective state and sleep quality. And then moving over to number 6, the cyclic alternating pattern. This is frequent microarousals, or which are brief brain, heart, and muscle reactivations that last between 3 and 15 seconds and occur 5 to 15 times per hour during the non-rapid eye movement stages. And this is part of the protective fight or flight response. And so it allows us to reposition, but also to recognize and react to a potential harmful or threatening situation. And so a high cyclic alternating pattern rate represents sleep fragmentation, and it rises with age, but also in the presence of disease. And so studies have shown patients with fibromyalgia have a 50% more cyclical arousal shift. So really showing the relationship between pain, chronic pain conditions, and sleep fragmentation. And another possible mechanism underlying this sleep pain relationship is the endocannabinoid system, which plays a role in the modulation of both sleep and pain. So I'm going to turn it over to Amy at this time.
Thanks, Disa. I'm so excited to talk about one of my favorite systems because when I was first, if you can advance the slide, I'm not sure. Thank you. When I first started learning about cannabis before it was legalized, I know I'm a bit of a rebel. I was like, help me understand why. Always going back to the why. And I had never really explored or learned in depth about the endocannabinoid system. And this system is so fascinating in the sense that it has this huge role to play in maintaining homeostasis. So we talk about eat, sleep, relax, forget, and protect. That's a huge job. So as I further dove deeper into looking at the endocannabinoid system, one of the things that stuck out to me was that we have more receptors in our endocannabinoid system than we do for opioid receptors. And I was like, help me understand more of this. So when, as a pain and symptom management consultant, in my previous role, this is something that got my attention of like, why do people use cannabis for multiple things? So let's explore that a bit. But the endocannabinoid system, as you see here, is part of, that regulatory function. It orchestrates a number of different physiological as well as neurodevelopment and immune regulation. And also want to pull in the sleep architecture part is that cannabinoids can interact and impact individuals with sleep disorders. So there's a role for THC and CBD that we'll talk about further in managing, but mostly I was surprised to see in the literature more CBD as an effective role in managing sleep architecture. Next slide, please. So this slide just shows how cannabinoids are, we have receptors. So we have CB1 and CB2. And as you see here throughout the body, how it infiltrates multiple areas of the body. And so we have CB1 receptors, which bind to THC. So 2 main components of cannabis that are often looked at. There's lots of components of cannabis, but it's really looking at THC and CBD. We also have CBN here, but I want to focus on those 2 receptors. So CB1 receptors are primarily found in that central nervous system, and it also can bring on more of a sedative effect. With some moderate dosing, you can get more stimulation, but the THC is really that component that can cause that euphoria feeling or a hallucinogenic effect in large doses. CBD, on the other hand, is what we call a non-competitive antagonist of CB1 receptors. So it kind of counter-affects THC, so it reduces that potency. So we'll talk about that synergistic effect of how they work together, and that ratio of THC and CBD is really important. It also, the medicinal properties can be analgesic and anti-inflammatory, also antidepressant, the CBD, as well as anti-anxiety. And so those CB1 receptors are primarily central, and the CB2 are primarily peripheral. Next slide, please. So the ratio of CBD and THC influence their therapeutic effects. And this is why with any medication, we start low and go slow. So it's multifaceted pharmacological actions of CBD. It's safe, it's favorable for, there are individuals who don't like the feeling of feeling high or euphoric with THC. So it's really non-intoxicating. That's the CBD component of cannabis. And so when it's used for sleep architecture, as well as chronic pain management, it's been used as an anti-anxiety, as well as epilepsy and seizure disorders. And then THC has that, usually can help with neuropathic pain management, but it has to also be used sparingly and low and slow, because it can have that more psychoactive effect of euphoria or someone feeling more high per se, so hallucinogenic, and that may not be a favorable experience for individuals. Next slide, perfect. I love this slide and this looking at how CB1 receptors, the distribution of CB1 receptors throughout the central part of the brain, and look at how many things it has an impact to. So the cerebral cortex, decision-making, emotional behavior. So not only do we get the peripheral effect of helping with pain and symptom management, we can have an impact on behaviors and emotions. So it just gives us a great idea of the complexity of our brain, but how the receptors of cannabis can impact our brain function and why people use it for multiple reasons. Next slide, please. So just to understand the difference between the different language. So cannabinoids are the class of compounds that act on the cannabinoid receptors in the human body. And then we have endocannabinoids, which our body actually naturally produces. Just like we have endorphins that give us pain management, we actually have endocannabinoids that we endogenously make in order to bind to that endocannabinoid system and those two receptors. The phytocannabinoids are those produced by the actual cannabis plants that I've been talking about. And then we have synthetic cannabinoids, which are synthesized compounds in the lab. And that would be our nabilone that we see, which is a one molecule of cannabis, which is THC. So that's something to highlight there as well. Next slide. So in the talk about pain management, the endocannabinoid system is so big, and it's also a part of modulating homeostasis, which gives us, which also helps modulate pain. So cannabinoids are often very effective in decreasing pain, neuropathic pain, but as well as inflammatory pain. So that's the balance of the THC and the CBD, and working and using those two together. Also, with sleep disturbances have been associated, like Disa talked about, with inflammation, inflammatory signaling, the cytokine storm. So when we can target the anti-inflammatory mechanism of CBD and using our endocannabinoid system, we can actually impact sleep quality. CBD has actually been shown to modulate the endocannabinoid signaling and interacting with different neurotransmitters, which play a huge role in pain management as well as sleep architecture. So when we target different pathways for pain management as well as sleep disorders, because it's multifaceted, we're trying to get an overall therapeutic effect of managing pain as well as helping better sleep. Next slide. This diagram just shows how we have different pathways of pain signaling. So we have our ascending, we have our central and descending. So this is why in the pain management world, we try to target the different pathways or different highways to modulate pain. And we have different receptors on those highways, and we also have different pharmacological and different approaches to target those receptors in order to disrupt the pain signaling. Now, I want to highlight here, because the talk is on cannabis, is that cannabis actually targets all three pathways: ascending, central, and descending. So when we're looking for an anti-inflammatory, when we're looking to manage somatic pain, when we're looking to manage neuropathic pain, we can get a multifaceted approach by using cannabis. It can be very effective for not everyone. We see that there are some individuals who don't have good pain management with cannabis, but the reason why it can work on three different highways with good pain management is because of this. So this is how, this is what this diagram is showing here. Next slide. I want to highlight the difference between synthetic and natural and why we don't just say, okay, yes, nabalone. Why do we have to use the cannabis plant? Why can't we just use nabalone? So nabalone, like I mentioned before, is a single molecule. It's only THC. So we're not going to be able to get the beauty and the dancing between CBD and all the other 100 components of the compound of cannabis in the plant. You have terpenes, you have CBD, and they dance together and they work together to bring an entourage effect for effective pain and symptom management. So nabalone is that THC. We have to do low and go slow at times when the formulary, if they only come in 0.5 milligrams, we're not able to, unless we use a compounding pharmacy, to start lower than that. It has a longer onset of action when taken and a longer duration of action. So once, we usually dose it Q 8 hours, and we aren't able to titrate it as well. So the herbal cannabis, as you see here, has many compounds to it. Like I mentioned, terpenes, it has CBD as well, that can give that ratio of working on multiple facets for pain and symptom management. So when someone actually inhales and smokes it, I know smoking in our medical world is this big no-no, but the reason why people actually smoke the cannabis is because they get immediate onset. Within 5 minutes, they're going to know, do I feel better? Is my pain being managed? Do I have a bit of euphoria and disassociation that I'm not actually experiencing and focused on the pain? I'm about to go to sleep and I want to be able to go into sleep quickly. So I don't want to wait for an hour for my oils to kick in. So there's a reason why people will choose an inhaled mechanism to deliver the cannabis. And then we also use oils. Sorry, I don't have that on the slide. I just noticed. And inhalation also is easily titrated. So within 5 minutes, they know what the effect is. When we use oils as administration, then you're going to get peak onset around an hour to 2 hours. You can also start low and go slow with oils. They can take a couple of drops, and then we can titrate to efficacy based on what their report is for reporting back if it's working or not. So the oils are actually something that we can work with as well. They have a longer duration, they last longer once you get the effective dose, but it can take time to titrate to efficacy. So something to consider when initiating cannabis. So opioid sparing effects. This is what was so interesting to me in actually anecdotally journeying with individuals who were using cannabis, is that because it contains so many different therapeutic properties and is targeting different areas, we found that individuals, and some studies had shown that individuals who started cannabis who were already using opioids, is that they could decrease their opioids. So it had an opioid sparing effect. And they were reduced by 30% or more after initiating cannabis. So when opioids have not so favorable side effects, it's something to consider when individuals are wanting to use or using it, that we can actually perhaps deprescribe and move into a lower dose of opioids. So CBD, being non-intoxicating, has demonstrated potential therapeutic effects in sleep as well. So it showed that THC can actually reduce REM sleep duration. We do use THC for individuals with PTSD who are having poor sleep architecture with nightmares, etc. We found that THC can be highly effective to decrease or to eliminate those nightmares altogether, though the CBD actually has shown in the research that it can help improve the quality of sleep by alleviating those underlying conditions that are impacting the quality of sleep, and also of increasing sleep duration. And final slide. So really to highlight the things that we've talked about. So to access pain treatment, it's a human right by the World Health Organization. So when we think about that human right, and that there's so many individuals that we journey with who have chronic persistent pain, I actually really like the language of persistent. I think it makes us pay attention more. Chronic pain is this word that's been used. It's like, oh, it's chronic, it's going to be there forever. But when we're like, oh no, this is persistent, it's like that persistent child that keeps asking for the cookie. The thing about persistent is that it doesn't go away. And we have an opportunity to journey with people and to look at holistically what's going on. So today, out of this webinar, I want you to think about the underlying sleep architecture. Have we managed their sleep? And are we able to manage pain with perhaps an adjuvant, and think about the endocannabinoid system? It's such a huge system in our body. Are we targeting those receptors to bring effective pain management? So looking at and thinking about those things. So we want to support good quality sleep to help manage pain. A way that we can use that is targeting the endocannabinoid system by using cannabis, and to better effectively manage pain.
Thank you so much, Amy and Disa, for this extremely comprehensive presentation, if I may say so. I'd like to open up the floor for the Q&A. We do have a few questions. I will begin to read one of them that I see in the chat from Rosemary. Hi, Amy. Would you recommend cannabis in palliative pain control?
Would I recommend cannabis? So as we saw here, the endocannabinoid system has so many layers of the eat, sleep, pain management, protect. We have seen it, research is still in its infancy. There's not a lot of great studies in pain management, but we do see anecdotally, like, let's go back to who's in front of us, the person, the individual who's using cannabis. I have seen amazing effects of using cannabis, of finding the ratio of CBD and THC and CBN, and finding different terpenes. So it's a bit of a journey for individuals. And I always give them that heads up, is that it can be, a journey to reach efficacy, to find the right ratio of CBD and THC. So long story short, Rosemary, I would highly recommend cannabis. It's not for everyone. There's stigma still associated with it that we have to overcome. There is access issues. So it costs money for especially herbal. Nabalone is covered. But it's a THC molecule. It's one single molecule. So individuals don't get coverage. Some people do get coverage under their insurance depending on their diagnosis. And I actually have found that many people with a chronic progressive life-limiting illness, insurance companies are covering them. So I'd always encourage them to look at that so that they have financial support in purchasing cannabis, oils. There's a couple of barriers, but there's also great, there's great efficacy in individuals using cannabis for pain management and other symptoms as well.
Okay. And then in the Q&A, we have a question from Ben Robert. In the context of possible allodynia when on opioids, would you expect Nabalone to eventually reduce some of that? if it's related to the opioid?
Yeah, that's a great question. Hi, Ben. Nice to have you here. I, when you're thinking about allodynia, I always like to think about when we're, especially hyperanalgesia, when we have to start decreasing those opioids, if all of those receptors are blocked and locked in, pulling in adjuvants is something that I highly recommend we move towards. I think NAB alone, because we have to go low and slow, it can be effective with neuropathic pain, especially if we're seeing that, individuals have poor sleep architecture. Maybe this can help with their sleep. I don't think it's a bad option. I think it's actually an adjuvant that I would highly consider to help just bring that whole picture, the total pain experience when we're looking at all those different pain highways. So if we're decreasing the opioids, but we want to pull in an adjuvant, Nabalone is something I would consider for sure. I think I'm a little bit biased. I'm way more like I'm pro cannabis, where I think other prescribers would say, oh, let's pull in our dexamethazones or pull in our GABAs to help support. I would probably recommend cannabis quicker than most, but that's my personal experience of what I've seen for patients. Disa, do you want to add to that?
No, I think that you touched on most of it. I don't have too much to add.
Okay, awesome.
I have another question from Shauna. Hello, ladies. I have a patient going into surgery for a lumbar foraminotomy. She doesn't do well with opioids. Would CBD be great for her as far as pain management and inflammation targeting?
Yeah, Shauna, great question. I don't know her, so I can't say, yes, I would recommend it for her. But I think doing your assessment journey with her, are there other things? What doesn't she do well with opioids? I know surgeons would always like to know, and anesthetists, what they're using and if they are using cannabis and the interactions. There's a lot of unknown interactions, though we do see great efficacy with CBD and decreasing inflammation, helping with sleep, which is going to be really essential for her healing. Also, skin integrity. We've used it on wounds for centuries. I think the first talk I heard was Dr. Vincent Maida was talking about, this is even before legalization, at an HPCO conference, and wound healing in individuals with HIV and AIDS and the role of cannabis. And I was like, what? That really sparked my attention then. And that was about 10 years ago. So there are great benefits to using cannabis. I can't say that it's going to work for her, and I don't know all of her history. So I think it's definitely something that you want to consider exploring with her and with her healthcare team.
Wonderful. And Nadine asks, would you recommend more CBD than THC if using more for insomnia than pain?
Great question. Disa, you can add to this too. So the research was showing, and I was surprised to see that CBD was actually preferred for sleep architecture, maintaining sleep architecture. It all depends on what's disturbing the individuals. This is where your comprehensive assessment, if we can impeccably assess, then our treatment plan is going to aim to relieve what the story is. So if it's hard to get to sleep, right, then I would say you probably want a bit of THC. It can really help calm. It can also make someone feel somnolent and can help induce sleep. But the research was showing that CBD actually helps increase the longevity of the sleep. So I think the beauty of cannabis is finding that dance of the ratio between CBD and THC and how they're working for that individual. So it's very individualized for sure. Disa, do you want to add to that?
No, I think just to reemphasize what you already said in terms of our comprehensive assessments, because we know that from all aspects of symptom management, that we really need to understand what the symptom is that the person is experiencing in order to tailor the symptom management strategies to that individual, because as of course we know, a blanket statement in terms of what will work for somebody is not going to work for everybody and in every situation.
Yeah, beautiful.
Wonderful. We have Lisa who's asking, who would be the best people or resources to speak with to determine what the best cannabis options would be for them and their specific situations and titration options?
Great question. So it's like anything. There's specialists out there. We can't be specialists at everything. There are GPs, there are nurse practitioners, there are palliative care physicians, prescribers, there are PPSMCs, nurses who have a great understanding of cannabis, of assessing what's going to be used. So finding those subject matter experts and resources is really key. There's also cannabis clinics. They became very popular when cannabis especially was legalized, but also from a medical standpoint, they were just like, okay, let's be a center, a clinic, to be a resource to help journey alongside people. So it's not anyone orders anything on the cannabis store. They are great resources. Olga's putting in the chat educanation.ca. So there's lots of resources out there. And I find the cannabis clinics, when I've referred individuals there, have been really great resources to help individuals. But if you as a practitioner are needing more support, I would find a mentor or prescriber, an authorizer, who is cannabis literate and is comfortable in approaching and not prescribing, authorizing. Thank you.
Thank you. From Karen Sudworth, we have, what is the main dose of cannabis? Do you happen to know?
Yeah, I actually had a slide on that, but I didn't put it up because I think it all depends on where they're getting their cannabis, the concentration of the cannabis. So it all depends. It's like if I have 5 milligrams per mil of morphine, then my dose is going to be different. So I didn't want to speak to that exactly and spend time there, because it all depends on the concentration and every producer is different. So I always say start low and go slow. Usually where they're getting their cannabis from will give you a starting dose, and it all depends on the individual. Are they cannabis naive? Or have they used cannabis before? Do they not like the feeling of THC? Do they like the feeling of THC? What are you aiming to achieve? But one of the things I would say to keep in mind when you are titrating, cannabis is lipophilic. It binds to the fat cells. So similar to our methadone titration, for those who are familiar with methadone, is that we have to go low and slow because they fill up they're lipophilic. So they fill up those receptors and then they spill over. So you may find that you have to take a few days to titrate to the next dose if you're not seeing efficacy with the initial starting dose. And then they get this like, oh, I started to feel good. So I always say to individuals, stick with me. I'm going to stick with you. We're going to walk this journey together, because people who have unmanaged pain, they get frustrated. They're like, I want this to work now. I want to feel this now. And then you get into a risk of over prescribing or using higher doses when you actually don't need as much. So I would walk the journey with them, really assessing what the dose they need, and that ratio of CBD and THC.
Okay, wonderful.
I think that brings up the point of trying to approach pain management earlier rather than later, because we know that when for people that are experiencing chronic pain for a long time and it builds and builds, and then you do have less bandwidth and less patience for different treatment strategies. And we know that it's not going to be an instant process with any type of pain management that we do. So really exploring it earlier rather than later, not waiting until we're in a crisis level.
Okay, super. I'd like to take this opportunity to thank Amy as well as Disa for presenting and being with us, giving us all this information. It was extremely comprehensive. Thank you so much to all of you, the participants that have joined us today. We always love hearing from you at the sessions. I have sent a link into the chat. We always want to get your feedback to see what you think about the session. The recording along with the slides will be provided within a week or so following the session today. And yeah, please stay tuned. Keep up with our website. Check us out. We have so many sessions upcoming. Thank you so much once again to our presenters and to everyone who joined us today. Thank you.